Welcome to eCancer TV in Bordeaux at the European Society of Surgical Oncology meeting. Three speakers are with me right now near the end of the meeting. Pierre Mordaunt from France, from Paris. Yes. Indeed. It's great to be in your country. On my immediate left, Linda Wild from Sheffield, and also Bert Bonsing from the Netherlands. You are, if I may say so, representing the younger element of surgeons here. We've been hearing from some of the older, more established surgeons, president, past president, future president of ESSO. What are your feelings? Perhaps I could start with you, Linda, your feelings about the developments you've heard here and the possibilities of improving things like quality, for instance, in surgery.
Well, I think the first thing to say is it's been a very educational meeting with some extremely respected speakers from all over the world, and certainly we've heard some very interesting talks presenting some of the most up-to-date advances in a range of different surgical specialties. I have two main specialties, breast surgery and sarcoma surgery, and we had some presentations from one of the most respected sarcoma surgeons in the world, Professor Murray Brennan from the Memorial Sloan Kettering Cancer Center in America, which was very interesting and informative. And also the current president of the EORCT sarcoma group talking about chemotherapy advances, which again was very state-of-the-art and very informative.
In both breast and sarcoma, we've heard about things like over-treatment, haven't we?
There's always an element of over-treatment, I suppose, in breast surgery certainly. There is concern about over-treatment, in particular in relation to breast screening, where we think we overdiagnose cancers in ladies where the cancers would never have troubled them during their lifetime. But I think it's generally accepted that that is a price that you have to pay to be able to treat people at an earlier stage. And you have to take the view that what you're doing is to the benefit of the population, not necessarily purely to the benefit of each individual woman. But for example, in screening, we know that we do definitely save lives from breast screening. The price that we as a population pay for that is that some women may be told they have cancer and treated for that cancer when that cancer would never have affected them. So you have to draw the line and set your standards somewhere.
And the treatment may cause other complications.
It may indeed, yes. Always, always.
And Pierre, at the Hôpital Bichat, you're specialising in thoracic oncology. What have you got out of the meeting so far, and what are your fresh feelings?
Oh, there are two different points. The first one is with the general management of surgical oncology. We get very good presentation regarding quality insurance and management in the operating room, which are like common to every specialty, so it has been very interesting. And some other regarding lung cancer, there has been some topic on like treating lung cancer in the elderly with interesting studies, so altogether it has been very informative.
Chemotherapy has become more prominent, or very prominent, in lung cancer, but do you think surgery is still the most significant factor?
I think so. Right now it's difficult to say that you are going to cure definitively a patient without surgery right now in lung cancer, because with either chemotherapy or chemoradiotherapy it's possible to have a control of the disease in certain stage, but it's not possible to achieve a long-term survival. So, and some of the agents of chemotherapy or targeted therapies have been quite disappointed. So definitively surgery remains a cornerstone of lung cancer treatment.
And presumably some of the new ways of imaging and some of the greater accuracy that seems to be emerging may be helping you as a surgeon?
Yes, there are some, what we have seen here is new tools to identify, for example, lymph nodes. Right now it's not applied in lung cancer, but maybe during the next step. We have seen some great thing about circulating tumor cells in breast cancer, but it may be also the next step in lung cancer. So that's the basis of this kind of congress, is that you can pick up something from other organs and try to bring into your own specialty.
And Bert Bonsing in the Netherlands, in Leiden, you have the privilege of treating patients with rectal cancer and pancreatic cancer. Neither of those are the easiest diseases to deal with. What's been new in this meeting that you've come across?
Well, what surprises me the most is that finally we get some centralization for pancreatic surgery and also for the more complex cases of rectal surgery going in Europe. There are promising results that in regions and in countries people are more and more aware that this kind of surgery is specialized surgery and should be treated in centers which can create in that way a high volume and get better results. And my view on this Congress is that it's the first time that everybody is really aware of that and is trying to incorporate that in daily business. So I'm optimistic about that.
What do you think are the reasons to be optimistic in both rectal cancer and in pancreatic cancer?
I think I'm optimistic because everybody gets more and more aware that to get better results, you need to talk with each other, how to describe in the literature how you treat your patients so you can compare and get to a higher level. And people are getting more and more aware of that. That is the main thing for both rectal cancer and pancreatic cancer. And I must say also that in the papers I've seen that we see that the treatment during the operative period is getting better and better. More people are getting through this kind of surgery in a better way, and that's a real achievement.
Now, we've heard quite a lot at this Congress about multidisciplinary approaches. We've heard about quality being very important. I want to ask all of you what you think about the way things are going, perhaps ladies first. The way things are going at the moment, as compared with how they were, there's a lot of huge experience from some of the surgeons of the past, but what do you think is happening at the moment, Linda?
Well, I think multidisciplinary team working is becoming the norm across Europe, and I think is translating into some big improvements in the quality of care. There's also greater standardisation, not only within countries but across the boundaries of Europe, where people are sharing best practice. There's a wider availability of knowledge about how to optimise treatment, and people aren't just being seen by one person who makes the decision about their care, perhaps in isolation of the best knowledge of optimised practice. Now there'll be a team of people deciding on care, a surgeon, an oncologist, often a specialist nurse with an interest or with a focus on the psychological aspects of the cancer, all working together to try and make sure that each individual patient gets the very best care for their needs. And that, I think, is really something that has become a huge theme in cancer management in the last 10 years.
And if I can ask you about one of your specialisations, breast cancer, there are huge international variations in outcomes in breast cancer. This is clearly due to the way you arrange it all. What are we doing right in some places and what are we doing wrong?
It's controversial because if you actually look at the data based on which the headline banner about variation in outcomes is based, a lot of the variation is actually accountable for by changes in data recording and data quality. And so I suspect if you could sub-analyse the data to get rid of that variation, you'd find that the variation was a lot smaller than it actually is. There are differences across Europe. We know that we have a lot of work to do in certain parts of Europe where they don't even have access to routine breast screening, and so those are issues that, as you know, people involved in ESSO were very keen to address. But I think generally meetings like this are helping to raise the standards across Europe, particularly the new accession countries, where perhaps their finances haven't been quite so strong, and we're trying to bring them into the fold and to help to raise their standards and give them as much support as we can.
And Pierre, from France, how do you think France performs extremely well in cancer? Is this in the realm of the surgeons, or is this more to do with the way oncology is organised at a national level?
Oh, it's because now things are getting more organized. It used to be very disparate with a lot of center, and we try to centralize it and to deal with cancer as a multidisciplinary approach. And at the beginning, surgeons were afraid of it because they used to think that they were losing the decision and they are going to lose patients. But what we have seen and what is reported in the Dutch experience with pancreatic cancer is that when you centralize the patients, you have more patients that go to surgery because the pre-operative care is better and maybe the surgeons are a little bit more active, and so altogether surgery do not lose patients. Patients are still well treated. So if we act with other specialty, we don't lose the decision and we don't lose the patient.
It must be quite difficult for surgeons to improve in lung cancer because the factors making the improvements may be out of their hands.
No, I don't think so. We have much to improve regarding perioperative care because right now the mortality after lung cancer resection is less than 3%, but it's still usually more than 1 or 2%. So we can improve that, and we can. The goal is to send more patients to surgery. So some patients are designed as said to be locally advanced, but we can try to make resection, larger resection. And the other thing is with metastatic disease, we know that it's possible to operate patients with metastatic disease, if it's only 1 or 2 metastases, we can operate the metastasis and the primary tumor. So that's the goal, to bring the more patients to surgery and to have better outcome for surgery.
And Bert, from your experience in the Netherlands with pancreatic cancer, can you give us any examples of just how organisation and particularly surgery needs to be improved to optimise results with those patients?
Yes, I think we're in the Netherlands now doing much effort to get audits working. So real correct data collection. And data collection makes comparison between centers, but also between countries possible. I think that in the former days, especially data collection is something which has an enormous influence on the results shown on congresses. And what we see, and has been shown here also on the congress, is that when your data collection is more sophisticated, you see that there are other trends which you normally not see.
So how much would you encourage surgeons to be more systematic and in fact very rigorously scientific in their approach? Are they, presumably they, at a very high level already?
We're at a high level already, but scattered. Not only in my country, we're working on that, but also in Europe. So we should get the same kind of definitions, the same kind of collecting of data, and then it's comparable.
Can I ask all of you how you react to the suggestion that, for example, hospitals or centres which perform better at surgery than others need to be informed and made more prominent, and those who are perhaps not doing so well should be informed that they've got to pull their socks up?
I think it's very important to have control on your case mix. What we don't want is that people who have a better or a less good position in front of the operation will be rejected because you want to have good numbers from your hospital. So I think that's not the way to go. The way to go is to see that you get correct data with a good case mix control, and when it's not okay, the numbers you make, then of course you should know that.
This has been a long-term issue about what you might call league tables, and it's been very controversial in the UK. And Bert makes the absolutely valid point that sometimes a hospital may have poorer outcomes because it's sent all the really difficult cases that the smaller hospitals don't want to deal with. It's very damaging then to say to that hospital, well, we're going to audit your work, and if you fall below a certain standard, we're going to stop people coming to you, because they will then start turning those difficult cases away. Now, obviously we need quality control, and most specialties now have good means of quality control. In the UK we have something called quality assurance and peer review. I'm sure there are similar systems in France and the Netherlands. And they have to look at the sort of cases referred in terms of the level of difficulty when they're assessing outcomes. Yes, there will be some units that fall below standard and that has to be addressed, but I don't think necessarily making the crude unadjusted data public so that patients can choose themselves is terribly meaningful if that data doesn't mean what it appears to mean at face value, if that makes sense.
Is it any easier in France, Pierre?
No, it's not easier. It's the same problem. We are focusing more on quality insurance because just having a look to the outcome, it's difficult. The case mixed is never perfect, and we know that there is a center effect where when you increase the number of patients you treat, at the beginning you increase your results, but at the middle of the bridge you will see that your things will go down a little bit, your results will be worst because you will have attract the more difficult cases. So this is a large center effect. We know this in surgery. So we have to look more at the process and the quality of what we are doing than just looking at a survival rate. Otherwise, we will only treat like people who are not really sick.
Now, I want to ask you all for a wish list. When each one of you is president of ESSO, what would you like to do for improving surgical oncology? Everybody's looking at you, Linda.
That's a difficult one to land on someone at short notice. I think there are so many things that would be nice to do. I think better quality training, I think, for young surgeons, which is standardised across Europe, would be quite high on that list, as would standardisation of protocols, standardisation and optimisation of protocols, so we can reduce some of the differences between EU countries which presently exist.
Same for me. I also joined the course of ESSO on liver surgery in the few days ahead of this congress, and there were some guys who operated a lot on liver metastasis from colorectal cancer. And what you see at that kind of courses is that the level of the group is growing within 48 hours. So I think that education of the people who should do the surgery is main topic. All the other things are very worthwhile, but training is essential. So that's high on my wish list.
Yeah, it's the same for me, because what we have seen in France is that the training used to be like only in the end of residence, and what happened now is that we have time limiting policies, we've got increasing technologies in the operating room, and we have to deal with both. So training should be maybe more organized, and it should be a great idea to go go to Europe and to see, because there are a lot of people, of expert people, and we can have a look because it's so close.
So good training is very high on the agenda.
Yeah.
What from this particular meeting of ESSO here in the beautiful town of Bordeaux are we going to take home as perhaps one or two of the really important things from each of you, practical things for doctors to remember?
I think from my point of view, it's that we're bridging now the gap between the very sophisticated CT scans and MRIs with near visible light molecular imaging to the operating room, so we can translate what we see on the photos to what we see in the patient. And that's, I think, one of the main topics in surgery during this Congress and my topics.
The message I'm taking home from this meeting is that the standard of care that we're giving patients across the board in surgery is improving year on year, which I find incredibly reassuring. And it's also highlighted a number of areas where we still have work to do, which I think gives us ideas for the next 10 years worth of work.
And I have been very well surprised by the Eureka project on colorectal cancer and the use of database in order to improve the quality of care. And just the hour after, I've seen a study based on a national database in France. And so definitively I think that's what I will do when I come back home, is trying to participate to those databases, and in order to have a better quality level and quality index to know and to be able to compare with other surgeons. and to give data in order to make studies afterward.
Pierre Mordaunt, Bert Bonsing and Linda Wild, thank you all very much for taking part in eCancer TV here at ESSO in Bordeaux. I look forward to seeing what you all come up with in the future.
Thank you. Thank you
Thank
for
you.
asking us.
Thanks a lot.